Hello, and welcome to the OT Meeting Room. I'm your host, Deborah Battistella, owner of Creative Concepts in Occupational Therapy. And today I'll be talking about the value of occupational therapy from a physical and rehab medicine perspective. That's where most of my experience lies. And I've been thinking about the role of OT when it's not a skilled program that's required from our patients or our clients. So as I was going through my thoughts in preparation for making this YouTube video for you, I had to do a little research and I kind of ended up in a little tiny rabbit hole, but I'm not going to take us too far down a rabbit hole. So let's move along here. So let's first talk about what skilled occupational therapy is. We look at this oftentimes from a rehab perspective, and skilled rehabilitative therapy occurs when the skills of a therapist are necessary to safely and effectively furnish a recognized therapy service whose goal is improvement of an impairment or functional limitation. This is from the Medicare website. Now let's talk about what is skilled maintenance. There's all these terms that are always flying around out there, and sometimes it's confusing for us as practitioners. So this information is based on the JIMO settlement, and it's taken directly from the Medicare advocacy website. So question number 5, when are skilled nursing or skilled therapy services to maintain a patient's current condition or prevent or slow further deterioration covered under skilled nursing, home health, and outpatient benefits? And this is assuming that all other coverage criteria are met. And the answer says, as long as all other coverage criteria are met, skilled nursing and therapy services that maintain the patient's current condition or prevent or slow further deterioration are covered under the skilled nursing, home health, and outpatient benefits, as long as an individualized assessment of the patient's clinical condition demonstrates that the specialized judgment, knowledge, and skills of a qualified therapist are necessary in order for the maintenance services to be safely and effectively provided. So here's where we're calling on our specialized judgment, knowledge, and skills of this person who's qualified. And if you're licensed to practice in wherever you live, and you are the qualified therapist. And so here's where we have to use our judgment and our knowledge to properly determine whether or not our skills are required for this person that we know and that we've been working with to either maintain their current condition or prevent or slow further deterioration. So it does require some thinking on our part. This question is also from the same website, and this is question 3. What are maintenance services addressed by the JIMO settlement agreement? And this slide says, these are nursing or therapy services to maintain the patient's condition or to prevent or slow further deterioration. And it goes on to say that even though no improvement is expected, there may be specific instances in the skilled nursing, home health, or outpatient settings where the skills of a qualified therapist and then nurse are required to perform these nursing and therapy maintenance services that would otherwise be considered unskilled. And this is because of the patient's special medical complications or where the needed services are of such complexity that the skills of a practitioner are required to perform it safely and effectively. So the JIMO settlement agreement clarified that such skilled maintenance services are Medicare covered services. This is a great website. It's the Medicare advocacy site. Then I found some information on the AOTA website and what they have to say about skilled maintenance services. And this is based on the JIMO settlement agreement as well. And AOTA states within the corrective statement, the core component related to therapy services and the maintenance coverage standard that is key to remembering when documenting your practice as follows. And I wanted to put documentation in here because I know a lot of therapists struggle with documenting, and it's kind of scary if you've had your services declined. It happened to me when I was a newer OT. I had put a patient on therapy who had dementia and they were declining in their ADLs, and I had no idea really how to document that, and I did not do a good job. And that entire program, the payment was denied. Fortunately, I was working for a company that was very supportive, and they understood that I was learning. And then I did my own research and found some mentoring that helped me be able to document better. And it's a little confusing if you're just getting started, or if you're changing practice areas, or if you're busy. Like sometimes it's just hard when you're busy to think about the words that you need to include in your documentation to support your and justify the skilled maintenance services. So this is the quote from the website. Skilled therapy services are covered when an individualized assessment of the patient's clinical condition demonstrates that the specialized judgment, knowledge, and skills of a qualified therapist, and here's where they put that skilled care in quotes, because this is where the skill comes in, are necessary for the performance of a safe and effective maintenance program. Such a maintenance program to maintain the patient's current condition or to prevent or slow further deterioration is covered so long as the beneficiary requires skilled care for the safe and effective performance of the program. And I love that AOTA put this on the page too. They said AOTA emphasizes that precision in documentation is key to demonstrating that your skilled services are medically necessary in all cases involving the maintenance coverage standard and beyond. And while it's easy to look at this, we read it, we see it, we know it, it's in the actual doing sometimes where we struggle. And so I highly recommend that you give yourself the space and the time to learn proper documentation. Find yourself a really good mentor. And I always, over the course of my career, have had so many opportunities to read the notes of other therapists, and you can glean from their information the people who write well. That's all I'm going to say about that. Okay. What is non-skilled maintenance? Well, again, from the AOTA website, I found a question and answer. So it was about what is non-skilled maintenance. So AOTA says that in terms of something being skilled, OT treatment requires a physician order. In addition, patients who no longer need skilled services but can benefit from a regular exercise or a group program, they should continue those activities as maintenance therapy, and that can be overseen by an aide, as these services are not skilled, nor are they documented or billed. So this particular question had to do with being in a skilled nursing and long-term care facility. So people who will benefit from continuing certain exercises or certain programs, but they don't need the skilled clinician to do it, they can be overseen by a caregiver, an aide, or something like that. And they go on to say that we're not billing, so we're not documenting these, we're not billing them. And these people are separate from those who qualify for skilled therapy, where they must meet objective, measurable goals. The issue is really what is most appropriate for the patients at their particular stage of function. And AOTA goes on to say that OTs can design a maintenance program for patients who don't require skilled services. And this is really where I wanted to go with this video for today, because there are a whole bunch of things we can do demonstrating our value, providing our OT value, that I think are being missed. And so the reason I think this is because I've worked in all levels of care. So I've worked in all levels of care in physical medicine. Also, I'm a fieldwork coordinator, so I'm in an OTA program. So I'm responsible for placing students in their fieldwork, their level 2 fieldworks, and I have a lot of communication with therapists and students. And this is a real thing. I have had students come back to me, as well as practitioners come to me and say, what can I do? Our OTs, our OTAs, they're not really providing valuable OT services. How can I help them be able to do that better? So a lot of these reports come back to me that in subacute rehab settings, in particular, not really with the inpatient rehab settings, but in the subacute rehab settings, it seems to me that there are so many practitioners who are missing a big piece here. So I first want to say, I want to bring our attention to the Medicare definition of skilled programs. That first paragraph, it talks more about skilled therapy. But then it goes on to say in the second paragraph, when the individualized assessment does not demonstrate such a need for skilled care, including when the performance of a maintenance program does not require the skills of a qualified therapist, because it could be safely and effectively accomplished by the patient or with the assistance of non-therapists, including unskilled caregivers, that's when these maintenance services are not covered by Medicare. And that's the part that I want to draw our attention onto, because there are things that people can do at home that we can help create for them and provide value in our practices. So let's talk about some non-skilled programs and the value of OT. So by the way, this stuff keeps coming to me and coming to my mind more and more because of the podcast that I started. If you're not familiar with my podcast that I co-host with Peter G. Levine, Peter is the author of the OT, oh my goodness gracious, sorry, Pete. Peter is the author of Stronger After Stroke. It's a great book. It's on its 3rd edition, and it's a great guide for survivors to use at home, but I use it as a practitioner. So Pete and I were doing this podcast, and these topics that we've talked about so far make me want to get myself back into a clinic and start doing therapy differently from how I've done it in the past. And that's easy for me to say because I have many years of experience under my belt. But as I think about that, and as I'm an educator, knowing that I'm an educator, I just keep thinking, how can we start doing occupational therapy differently? It does seem to me that the medical model, it's not, it's designed to keep people circulating through a system. And when we only think from the medical model perspective, we keep ourselves as OT clinicians in little boxes where we're not doing all that we can with the knowledge that we have to support each other, support the clients that we serve. So that's kind of where this is all coming from. And also because I created a mirror therapy program and I also, oh my God, there's so much. So I also have a video library, an ADL video library, because I've interacted with so many people who wish that they had different and more when they went home. So based on, and also I've been a patient and I needed to have some therapy for my shoulder. And I just, I was given these handouts. There was this one exercise that I always did wrong when I got home. And if I just would have had a video for it, I could have done it so much better. And so the clinic that I went to, they didn't use videos. I know a lot of physical therapists are using videos, and I just think it's high time that OT step up our game. So if you're the kind of person who wants to step up your game, keep listening, because I've got some ideas for you, and hopefully this will spark that little thing inside of you where you take this information and stretch yourself to do and be a little bit more than you have been. So when we look at occupational therapy and our value in a non-skilled program, what does this require? Well, it's going to require some thinking on our part, and we're going to have to think about the future. So really what we're doing is thinking about a client's success beyond their time with us. So once they're discharged, what can we instill in them, provide them with, help them with, that they can take with them and continue doing, that will help them to continue along a journey towards health beyond just, surviving maybe. Which is why I love OT, because we're always about the person and living life to the fullest. So what you have to do in order to do this is use the skill, your skill now, while you're with them. Think about beyond their time with you. And you can start educating them now and developing a habit routine program for them based on whatever program, a maintenance program that you think they would benefit from for after they're discontinued from therapy services. This can and should start when they're in an inpatient facility, whether it's inpatient rehab or subacute rehab. If they're receiving home health services, they have access to you a certain number of days and hours per week. And I know when I was an outpatient patient, my therapist told me that people get better not here. They get better with what they do at home. And therapists always know if somebody's doing their home program because the healing occurs more quickly, a person gets stronger faster. This is all stuff that we know that we can be applying to our practice. So what do we have to do? We have to use our clinical reasoning skills. So this requires you to use your skilled OT knowledge. You're going to think about a person's diagnosis. What are their deficits? What is it that, are there any contraindications to exercise, or do they need, and when I say exercise, I mean are there exercise. Are there any contraindications to activity? That's really what I was thinking of, because here I am preaching against just doing exercise, and I use the word exercise. So anyways, are there any contraindications in their activity based on a diagnosis that they have? So for example, somebody who has had a hip replacement and they have the bending restrictions, someone who has had open heart surgery and they have lifting restrictions or arm mobility restrictions. That's where we're going to use our clinical reasoning skills. Think about all of those things. And then start thinking immediately about what can they do at home, knowing that their time with you is limited, and knowing that when they leave you, they will likely still be at a level of deconditioned. And there will still be some healing that needs to occur for them. So that's where you're going to think about that and think about what they could do on their own. And then you're going to make sure that it is appropriate for their current situation, and whatever program you design for them, you're going to ensure that it's safe for them to do on their own. And while you're in working with them, during your time with them, you're going to think about, how can I help them establish a routine so that this becomes a habit for them, so that they have no questions when they go home. They feel fully supported by you. They feel confident in engaging in that home program after they leave you. Because as a patient, from the patient's perspective, it is unnerving when you're doing something and you don't know if you're hurting yourself more. And that's me as an occupational therapist. And I have knowledge of diagnoses, but when it's you and your body and it's something new and different that you haven't done before, it can be a little unnerving. And that's the other point that I want to bring in. This is new. A lot of times these situations are new for people. They are experiencing some sort of a traumatic event, an interruption in the flow of their life. And it's very overwhelming. And so if people are sick and they're overwhelmed and they just are deconditioned, not feeling well, and they have their own worries going on, it takes longer to learn something. And that's why, to me, it makes sense if we implement this stuff while they're with us and encourage them, within the boundaries of whatever's going on with them, to do more. And this is when it is skilled, when they're with us and we're using our reasoning, our knowledge to help guide them along a journey, step by step along this journey. So please don't think that I'm saying, just throw something at them. No, this is really where we are using our knowledge, our skill level. I cannot emphasize that enough. And the nice thing about doing this, when you have someone in your care, you can ask them to show you what they've been doing. Show me how you've been doing the program that I gave you to do when you're outside of therapy. And you can check on them. You can see how they're moving. You can talk with them about how they think it's going. And then you can make those modifications. That's the skilled part, where you're making those modifications, where you're setting them up for success when they leave you. I hope this is making sense. So here we are, we're thinking ahead to discharge. We have to think about the setting that the client is going to. Will they be going home? Will they be going home alone? What supports do they have in place? Are they independent? Are they still going to be receiving some skilled services when they leave? Supports that are in place, those are really important. So for example, thinking about if somebody is not independent and they're going home, does the caregiver live with them? Will the caregiver be there 24 hours? Can they be left alone? Those are the types of things that we're thinking about. And that's, again, where our skilled knowledge comes in, our clinical reasoning skills. So what supports do they have in place? What supports are needed? And thinking about the costs that are involved with those and the resources that they have available. If you're providing, a lot of people are still giving paper handouts, and paper handouts, they do present a cost to a clinic. I can't tell you how many people have told me that they don't use those paper handouts. They end up in a pile. So if there are resources that you have that you can connect them with, that you think are valuable to them, ask them, show them what's available. Say, is this something that you feel would benefit you? Is this something that you feel like you can afford? And along with that, a lot of times we're so quick to think people can't afford things, but our understanding and knowledge of the healthcare system and health can come into play here. So I've given talks at stroke support groups. And I love to bring adaptive equipment with me because people get such a kick out of that stuff. And some people are so thankful to learn about it. And then there will always be one or two people that say, but this stuff isn't covered by my insurance and it's very expensive. Well, actually, not all of this stuff is expensive. And if you take a look at cost of a piece of adaptive equipment or a book that you want somebody to buy and read or something like that, and you compare that to the cost of a hospitalization in terms of money and the part of life that it takes you out of. And when there's no value that you place on health, and just helping people to understand that, it really does help shift a person's perspective. So that's where, again, I love being an occupational therapist because we build this rapport with our clients, and we can have these meaningful conversations. And if you think about yourself and change, you don't just change. Nobody just says, oh yeah, I'm going to start, A, B, or C today. No, this is something that occurs over time. So if we think about ourselves as one step in their journey, and if we can have that relationship and that rapport with them where they value the suggestions that we give, they may integrate those things. So I always include the OT and the OTA resources, like your knowledge and your resource library. Those are super important things to have. And they're all items that you can offer to your clients. So in a previous presentation that I made, I said, when you know better, do better. I love this quote by Maya Angelou. And occupational therapy, being a service provider, is an ongoing, evolving journey ourselves. And as we expand in our practices, we start doing better. So I always want to give strategies for how to do better, which I kind of did in the last slide, but I'm just going to reinforce those things. So 3 strategies that you can do right now to develop a non-skilled OT program for your clients are just start where you are. Know what your client values. Know who they are and what their goals are. Learn from them. So I'm going to tell you in the podcast, Noggins and Neurons is the name of the podcast that I do with Pete Levine. We had a lovely conversation with a stroke survivor who, this woman, oh my goodness, she really did such a phenomenal job. She listened to her therapist and she did more than that. She's very inspiring to listen to. Her name is Kathy Spencer. It's Noggins and Neurons, the survivor interview, if you want to look that up on iTunes or Google Play or Spotify. We're all over the place. And she is an example of a lot of people that we work with. They don't want just the time that they have with us. So know your clients, know what their goals are, find out what is their motivation level, all of this model of human occupation stuff coming into play, and start discussing with them as soon as possible. When you start the discharge plan, you don't have to tell them that you're talking about discharge, but you can say, I'm looking to the future now so that I can start planning the best way to support you when you're discharged from therapy. So knowing what their strengths are and aligning that with their goals, you can start creating a home program that's appropriate for them and have them start doing it during their time with you. And as they start doing this during their time with you, they will have more confidence in their own abilities. They will start to feel better. And as they do that, I think their independence will also increase. But you'll also be able to know, does this person require supervision? Is this something that they will need a caregiver or support for when they leave. So that's when you're going to start thinking about appropriate home supports and the resources that they're going to get from you. And again, your skill comes into play, your skilled knowledge comes into play when selecting those resources. And, if they require technology, then making sure that they have the technology available to them, using your time with them to get them started using that technology, talking with caregivers. Caregivers are really, really important in this stage. And then asking them, are there some resources that we can get in place for you before you leave? So for example, if somebody wants the video mirror therapy program, you can offer for them to go ahead and pay for that and get them going with that while they're still in therapy. If somebody really wants that book, you can, Pete's book, for example, you can help them purchase that book while they're in therapy and then use that book, go through that book with them, have them pick out the items that they think are valuable to them. In all of these interactions, this is how you're learning more about your client and setting them up for success in these non-skilled programs. I gave you some resources that I like to use personally. I put my website on there, creativeconceptsинot.com, because the home mirror therapy program is on there and the ADL video library is there. I put a link for Pete's book, Stronger After Stroke, and his blog too, which is a really good blog. And then the OT toolkit. I know a lot of people still use the OT toolkit. I'm promoting my own stuff, but I'm also promoting other things because we need to have a sizable library of resources for ourselves to offer our clients, because not everybody can use the same things and not everybody needs the same things. So yeah, so those are the resources that I have. And then there's also the references. So these are great references if you want to learn more about the difference between skilled therapy, skilled maintenance, and then non-skilled maintenance. I hope you enjoyed this video. I hope you found value out of it. And if you could just take one piece of this and it helps your practice, then that makes me happy. Make it a great day.